Well, good day, everybody. My name is Floris Schreuder. I work as a vascular neurologist at the Department of Neurology at the Radboud University Medical Center in Nijmegen, the Netherlands. And I'm here today with Professor Saskia Middeldorp from the Department of Internal Medicine, the Radboud UMC, as well as Dr. Truman, who is an associate professor in emergency medicine at Dell Medical School in Texas, the USA. We'll talk about the results of the ANNEXA4 study, which evaluated Andexanet Alfa for the bleeding in patients while using a factor 10 inhibitor. And first, Dr. Milling, as being the first author of the abstract, can I ask you what you intended to set out in the study?
Well, I think, it is the final analysis of 479 patients, and it does confirm what we've seen in the previous interim analyses, that there's this very rapid drop in anti-10A levels. And consistently, there's an associated 80% hemostatic, good or excellent hemostatic efficacy in these patients with life-threatening and major bleeding on factor 10A inhibitors. But in addition, we found some interesting correlations. I mean, the three variables we care about are anti-10A levels, mortality, and hemostatic efficacy. And while there was no correlation across these variables, in all patients, when we looked at the under 75 group and the correlation between hemostatic efficacy or between anti-10A levels and mortality was quite robust. And then again, as we reported before in a paper, in an interim analysis, there was a very modest correlation between hemostatic efficacy and anti-10A levels in the ICH subgroup.
Okay. That's very interesting. And I was wondering, when looking at the abstract, you included both patients with intracranial and extracranial hemorrhage. The majority was patients who had an intracranial hemorrhage. What kind of hemorrhages were these? Were they spontaneous hemorrhage or traumatic hemorrhages?
Yeah, so of the 2/3 of the 479 are intracranial hemorrhage. And the majority of those are spontaneous, with about a little over 100 traumatic intracranials, and a couple hundred of the spontaneous. Outside the cranium, it was about 29% GI bleeding, and then 10% other, meaning that could be everything from pericardial bleeding to epistaxis to GU bleeding. But you're right, the majority of it was intracranial.
Okay, very interesting. And Professor Middeldorp, may I ask you what the primary outcome of the study was?
Yeah, so the primary outcome of this study was the decrease in anti-10A activity levels that are reflecting the levels of the oral factor 10A inhibitor that was taken by the patients. So the primary outcome was the decrease in factor 10A levels or activity, and the secondary outcome, of course, was even more important to the patient, which is the clinical efficacy. So either good or excellent, or poor. I think it's really important also to stress that all these efficacy outcomes, the clinical efficacy outcomes, were centrally adjudicated. And also the index bleed, so the qualifying bleed to enter the study, was also adjudicated centrally for eligibility. So I think it's important to stress that this is a very, very large cohort and very robustly evaluated.
Mm-hmm. And just moving just a bit more in depth about the secondary endpoint, how was the good or excellent hemostatic efficacy, how was it defined? Because you have various kinds of bleedings. How did you try to verify that?
Yeah, so for intracranial bleeding, and you are a neurologist, it's I think that it's the most relatively easy way because you have MRI or CT scans. So for instance, excellent or good clinical hemostatic efficacy for intracranial bleeds meant that the volume increase would be less than 35%, because as you know, of course, you would expect some hematoma expansion also after the first diagnostic CT scan. And for all types of bleeds, there are clear and verifiable, objectifiable criteria that were actually put together by Schreuder for one of the registration trials of PCC or plasma for vitamin K antagonist-related bleeding.
Yeah. One of the things I noticed, and that's the final question I have for you for Professor Middeldorp, is that in the abstract you report the percentages of reduction in the anti-factor 10A, anti-factor 10A activity. It's a whole mouthful. And for apixaban and rivaroxaban, those were quite high, up to 90%, whereas for rivaroxaban and the enoxaparin, they were quite a bit lower, about 75%. Yes. What do you reflect on that?
So I don't know the exact mechanism. Maybe Dr. Milling can elaborate a little bit on it, but we should bear in mind that the numbers of patients treated with edoxaban or enoxaparin were very much smaller than the patients in the study who were treated with rivaroxaban or apixaban. And that doesn't mean anything about the risk of bleeding, but it really reflects the prescription patterns. I do not have a clear explanation for it, but I do think it is important to realize that the point estimates of the clinical outcomes were similar across the anticoagulant used.
Okay.
Yeah, that's a fair point. The confidence intervals in 30 patients are going to be very wide, and of course, we don't really know that it's right there in the center. It's just there's a 95% chance it's somewhere in there. However, we do hypothesize, because the volume of distribution is so much, for instance, for edoxaban, the volume of distribution is so much larger that when you bind it in the vascular space, you get more of it coming in. That said, I mean, there's no control group here, so these are all correlations. But that said, the thrombin generation, which we also measured in the edoxaban group, was maintained throughout the entire 12-hour period. And of course, with all that variability in such a small sample, but the reassurance from the thrombin generation, I'm not sure that there's a disparate effect, but we would need a larger sample to really tell that.
Mm-hmm. Yeah, so there's more research there. May I ask you, Dr. Milling, another question? One important concern, of course, of giving hemostatic agents is the risk of thromboembolic complications. What results did you have on such events, and how does it relate to the literature?
Yeah, so much has been made about thromboembolic events in reversal trials, and I've been involved in most of them across the years. And we need an abundance of caution. So we capture these events out to 30 days. But to me, it doesn't seem entirely reasonable to ascribe one dose of a reversal agent to a thromboembolic event 30 days later. It seems to me that the more reasonable explanation is there's a failure to restart anticoagulants. And this was very clear in the data. Those who get there's all sorts of confounding by indication when we talk about who gets restarted, because we're not randomizing restart. There are trials that are doing that now, and I think we'll have definitive answers soon, but we're randomizing before that. So given all the biases, though, this is an important finding. Nobody had a thrombotic event after restarting full oral anticoagulation, and 0 is a pretty powerful number, right? If you restart them, they don't have thrombotic events. So we really need to be thinking about that. We're not done when we reverse them, and that's a bias toward emergency providers like myself, right? The bleeding's over, we can stop worrying. No, you have to think about restarting that anticoagulant, because this is a prothrombotic patient who was on it for a reason, and we can't leave them unprotected.
I think that's a very clear message, and I think that's one of the things we might conclude with. Do you have any other final conclusions for the audience to take home?
Well, I think it's an effective therapy that has an understandable mechanism, and the mechanism works. We've seen that over and over in healthy normals and multiple populations of types of bleeding patients. The 10A drops very rapidly. We need a randomized trial, and there is one ongoing. We always want that definitive randomized evidence, and we'll get that answer soon, I think.
Well, thank you very much, both of you. Very interesting study to hear the results on, and I hope to talk to you soon live in person.
Yes. Nice talking to you.
Thanks.